Good evening. Welcome to tonight's AO North America Hand Education Committee web-based learning series entitled Sage on Stage. My name is Jay Bridgman. I'm the Division Chief of Hand and Upper Extremity and Microsurgery in the Department of Orthopedics at the University of Missouri, as well as a member of the AO North America Hand Education Committee. I'll be leading tonight's session, and our sage tonight is Chris Pederson. Now, Dr. Pederson is a master surgeon, renowned educator, and leader in hand surgery. And he has served on the board of the American Board of Plastic Surgeons, as well as the director of the American Board of Plastic Surgery. He's been on the executive council of the American Society for Surgery of the Hand, past president of the American Society for Reconstructive Microsurgery, and American Association for Hand Surgery. Several awards including invited visiting professor, American Society Surgery of the Hand, American Society of Plastic Surgeons, American Society for Reconstructive Microsurgery. He's been a long-term editor of Green's Textbook of Hand Surgery, editor of Journal of Reconstructive Microsurgery, editor of Plastics in Reconstructive Surgery, over 80 peer-reviewed journal articles and book chapters. And significantly, as a renowned educator, over 23 years training hand surgery fellows, 79 hand surgery fellows, at the Hand Center in San Antonio as the fellowship director. He currently is the head of hand and microsurgery in the Division of Plastic Surgery at Texas Children's Hospital. So it's a great honor to have Dr. Pederson with us tonight. I am Jay Bridgman, as I mentioned. Dr. Paul Binhammer is our moderator for questions from the University of Toronto. And these are our disclosures. I want to remind you about Zoom etiquette. All your microphones and videos have been turned off. Please send your questions through the question and answer tab at the bottom of the screen. Dr. Binhammer will review the questions as they appear and present them to Dr. Pederson. And we're going to use question and answer for questions related to our discussion topic. I want to remind you about this is our 5th in the series, and our past leaders, our past sages, their interviews can be accessed on YouTube. And so this is a schedule of our past sages as well as our upcoming meetings. So please join us. You can access the recording of this internet series. It'll be sent out 24 hours after the webinar is completed to those who are registered. And we want to remind you that every Thursday evening, our hand education series has a must-know series, How I Do It. This Thursday night, July 9th, is tendon ruptures about the wrist, assessment and management, as well as the video and learning sessions for the ulnar artery perforator flap. We'd love for you to join us, so please register for that weekly session. All right, and with that as a beginning, I'm just gonna stop my sharing here. And I just wanna say thank you, Dr. Pederson, for joining us tonight. Tonight, our session is really more discussion, you could say, in topics on leadership. And our first topic is on mentorship. And so my first question to you, Dr. Pederson, is how has mentorship developed as a theme in your career? And specifically kind of in a subset of, if you could cover different eras of your career, including maybe even before medicine, during your medical training in hand surgery, microsurgery, and then finally a mentorship in your career and how that's impacted you.
Well, thanks, Jay. I want to start off by saying that it's really a great honor for me to be included in this series. I'm from a small town in Texas, and so this seems pretty fancy, but it's very nice, and I appreciate it. I would have to say, I've been thinking about this. We talked about it before, but probably the person that wanted me or encouraged me the most and really made me want to go into medicine was my grandfather. He was a country doctor in East Texas and practiced in a little town until he was 88 years old. He didn't turn anyone away. The poor people called him Dr. Jesus, and so he really influenced my decision to go into medicine. I happened to work in a hospital in the little town I grew up in, Texas City, starting at 13, and I really came to love the surgeons. And I'll have to admit, particularly the orthopedic surgeons, I can't remember any of them specifically mentored me, but I thought they were the coolest guys. I don't think there were any hand surgeons there at that time. I went off to college. I was at the University of Texas, and I was in the band. And actually, a great mentor for me there was a guy named Vincent Danino, who was the director of the Longhorn Band. Until a few years ago, at the age of 90, he would get up at the football games and still direct the band. He was a wonderful guy. But he basically taught me that if you were good enough at what you do, you could let a few other things ride, which maybe is not a good thing, but nonetheless. And then I went off to medical school, and it was interesting. I don't remember any really good surgical mentors there, but there was a gentleman named Gene Wilson, who was a famous endocrinologist. He was an editor of Harrison's Internal Medicine. He was in the National Academy of Sciences, a brilliant guy from a small town in Texas, but he desperately wanted me to go into internal medicine, and I just couldn't stand the thought. And I remember when I was getting ready to apply, I went and talked to him for a letter. He wrote me a wonderful letter. But he said, well, if you're going into surgery, you must go to Duke, because David Sabiston is the only surgeon I know that's not a complete son of a bitch. And so I thought, okay, but I looked into Duke and it was a little complicated. But subsequent to that, I went to San Antonio and did general surgery. I had several mentors there, some really good surgeons, but I started to appreciate that. And then I headed off to Duke to do plastic surgery. There, I met a fellow named Bill Barwick. Bill was a young attending, wonderful guy, great mentor to many people. And he really got me interested in microsurgery. Duke was a weird place because sometimes everybody didn't get along that much. But nonetheless, I did my training there, and then I went to Louisville. And I'll have to say, Louisville was a wonderful experience for me. Harold Kleinert was a soft-spoken, wonderful teacher, but somebody that really took an interest in me was Sumin Sai. There was an episode one Sunday in Louisville where a double arm amputation came in, and I was kind of backup call. And I remember everybody was excited. They were going to do a double arm replant, never been done before. And basically they told me, you work the ER. Somebody's got to cover the ER. And it was I'm going, this is terrible. Well, a clean cut thumb amputation came in about 11 o'clock. And so Louis Schecker was one of the attendings. I saw his name on the list, I believe. And Doug Hannell was a super fellow as well. And I went up to Louis and said, hey, we've got this thumb amputation. So he said, well, get it upstairs, get going, I'll come help you. So I got it upstairs, and there was a good surgical tech, and he went, well, come on, Dr. Pederson, you know how to put some K-wires in. So I put some K-wires in. And Louis came in and said, how you doing? I said, well, I'm going to probably do some tendons. And Louis said, well, you know how to do that, and I'll be back in a minute. So I did the tendons, and then the scrub tech said, well, Dr. Pederson, let's do some vessels. So I sewed the artery. Well, to make a long story short, I ended up doing the replant by myself completely. Louis Schecker never scrubbed. And on Monday morning, Dr. Sai came up to me and said, oh, you did a replant by yourself. You want to help me do a median nerve graft? And so from then on, Sumin Sai and he was really a great mentor to me in Louisville. And he's someone that's really followed my career and been wonderful. Then I went to Australia, spent a year at Bernie O'Brien's place. The best person there for me was a gentleman named Julian Prebaz. Julian is probably the most creative surgeon I've ever known. And for me, the people that I really respect are creative surgeons that can think the problem and come up with a really creative solution. Julian went on to Boston after that and was at Brigham for many, many years, and the program director at Harvard. He's not a hand surgeon, but he's a brilliant reconstructive surgeon. He's in Tampa now because of politics in Boston, but out of the people in Australia, Julian was really the best for me. And then I went back to Duke and went on the faculty, and I was the first person at the time that was a plastic surgeon that took hand call with the hand fellows. And I didn't know him well before, but Jim Urbanek, who I think everyone knows was the chairman of orthopedics, became really one of my best mentors. We did cases together. I showed him how to do a couple things. He showed me how to do a lot, and became also very interested in my career. And then after a couple of years there, the draw to go back to Texas was strong. So we went back to San Antonio and the university there. And that was not a very good job. I was by myself. I was getting murdered. And eventually, David Green, who was very standoffish in the beginning, offered me a job. And I remember when I first interviewed with David, he said, well, I think you're a luxury. You're not really a hand surgeon, but we need a microsurgeon. So David, I was with him for 27 years, and he's the best guy, the best partner. He was like my father, who passed away when I was an intern, for many, many years. And David helped me and promoted me, and I think did all those things that a mentor is supposed to do. And then I kind of wanted to go back into full-time teaching. So I got a great offer to come to Baylor. And now I'm a mentor, which I think is great. I mentor the young surgeons, my partners, as well as the residents. And I don't know, I rambled on, Jay, but I think that's kind of my history with mentors and, the people that have really, really helped me in my career.
So a couple of the parts of your story that stand out to me that I'm interested in include, why did you go to Australia? What was at that time, did you need more exposure to other people in microsurgery? It's kind of an early era of microsurgery in the United States. So what was the thought process at that time?
Well, when I was in Louisville, at the time, they would have 8 fellows from the US and 8 fellows from overseas. And there were 2 guys from Australia. And I got to be very good friends with both of those gentlemen. And they both said, gee, you ought to come to Australia. Well, I had and still have a wonderful wife for 43 years. And she was game. We had a 2-year-old at that time. But I said, let's go somewhere else and live for a year. All her friends said, you're not going, are you? And then she got pregnant. She went 7 months pregnant to Australia, and our son was born there, which was kind of bizarre. But, I just wanted to see something else and see the rest of the world. I don't want to be negative, but, the training in Australia probably didn't train me a lot. But the best part was the other fellows. When I was there, the primary people I worked with were Katsutara Doi, who is now world famous brachial plexus surgeon. I probably learned more from Doi than half of the attendings. Doi had done more toe wraparounds than Wayne Morrison, not to say anything bad about Wayne, but he invented that operation. But Doi had done more when he got there than Wayne. Wow. And I learned more in the middle of the night from Doi doing replants than I did most of the attendings. The other fellow was Rakesh Kazanchi from Delhi and Giorgio DeSantis from Italy. And that group of 4 are fast friends. We have all been the presidents of our national microsurgery societies, and we've also all been to each other's meetings. And so I encourage all the young hand surgeons and microsurgeons. It's a fairly small community in the world, and it's so great, the interaction between microsurgeons and hand surgeons around the world. And I encourage everyone to take part in the international meetings, et cetera. Hopefully when we have them again. So,
yes. So when you think about those different people that played a role in your career as mentors, what do you think makes a good mentor? Like I would say that this question is based in fact that I talked to several of your colleagues and people you've trained, and they all said that you're a great mentor. So as a starting point, what do you think you took from those people to kind of make your own mentorship style per se?
Well, I think it starts out with being a good teacher. I think you need to be interested in the people more as individuals than, for whatever. You have to be able to help them in their career if you can. And I think there are people that, you want to help and you want to be future colleagues. I've been in some situations in my long 9 years of training where they didn't treat us like future colleagues, which I think is ridiculous. But, my mentoring style developed from David. David Green was a person I could go to and ask almost about anything. And he would give me an honest answer based on nothing, with no agenda. And that's what you need in a good mentor. You need to be able to bounce ideas off them with no repercussions in terms of, what a stupid idea or whatever. And I really think, I hope that my former fellows all feel free to call me at any time. But, I've found that the ones that need to call you don't, and the ones that don't need to call you do. And you don't worry about those, because they'll call you and say, well, gee, Dr. Pederson, the flap's kind of blue. What should I do? And I go, you know what to do. You take it back. But nonetheless, my career has been strongly influenced by strong mentors who helped me in my career and were interested in me and always were there to talk to. And I think that's kind of the basis of what I try to do in terms of helping, in promoting their careers. So.
And it's interesting you say that, because that's what the people I spoke with said about you, that this is a person you can call anytime. I think it's interesting that as you describe it, availability and just being willing to talk to a person that needs, advice or to discuss a case or things like that is so important. I know it's been important for me. And so it's really great to hear you kind of go through those ideas.
I would just add, not to interrupt, but I occasionally hear from a fellow I haven't heard from in 10 or 15 years to ask me about something. And I love it. I love talking to them. I love emailing them. I love seeing them again at the Hand Society, at our reunions. So yeah, if any of them are out there, as I said, I call me anytime. I think they mostly know that. So.
I also love that theme about your trip to Australia, because you never know how an experience like that's going to turn out. These incredible people that you met, you probably didn't anticipate that before you went. I know that early on in my career, I had some abilities to work in, overseas and in different environments, and it's been really impactful for me as well. And so I think that any opportunity people have to work abroad or do a visiting scholarship or visiting, professorship would be good, or visiting fellowship. What regrets do you have, not necessarily about your career, but maybe just in, maybe early on in your career, working in a new hospital? Or I know for myself, you talked about, departments that do get along or don't get along. Maybe there's things that you learned from those situations. What are some advice you'd give to a younger Chris Pederson based on what you've learned in your career?
Well, I'll tell you a funny story. I had never had any orthopedics in medical school. And when I was an intern in San Antonio, I got orthopedics. I was the only intern in general surgery. I got it in May and June. And I was on a service with Jim Heckman, was the chief of the service, who became the editor of JBJS. Tommy Clanton, who was the chair in UT Houston and now at the Stedman Clinic, and a guy named Steve Dickout. And the chief resident, I don't remember who he was. He was never around. It was the end of the year. But I loved orthopedics. I thought this is the coolest thing. And the funny thing is the two guys, the residents with me, said, man, you ought to go into orthopedics. You're a great fit, Pederson. You're a good guy. So Charlie Rockwood was the chairman. And I remember I met Dr. Rockwood at lunch. And I said, Dr. Rockwood, boy, I'd really like to go into orthopedics. But, we're talking about June. And, Rockwood kind of talked like this. And he goes, well, Pederson, they really like you. But we just got our internship class, and do another year. And then we can probably find you a spot. And at that point in my career, I didn't know I was going to do 9 years of training. And I said, forget this. I don't want to do it anymore. So in hindsight, I'm kind of glad that I finished general surgery, because one of my interests has always been vascular problems, which I can probably do better because I did general surgery. In terms of, regrets or things I would do differently, I'm probably too trusting, and I'm a very non-cynical person. I don't want to be cynical about this, but I would say there've been a number of times in my career that I trusted people to do the right thing, and they did not. And for various reasons, it may have reflected poorly on me. So I think you need to be a little aware of people. I've written things for various things and never been given any credit. And so I think you just need to be aware. I think I was naive. I continue to be somewhat naive because I trust people. Yeah. And again, I really have no regrets. I've had a wonderful life. I have a wonderful career. I have a wonderful family. So I really have no regrets at all. But I think young people, you need to be careful. You need to be careful who you're dealing with. And the problem is the politics of the situation, which you may and may not know. And you may be doing a big faux pas and have no idea about it, which I have certainly done. And in the long run, it doesn't matter. But at the time, it was pretty painful for me. So.
Well, at this point, before we go on to our next topic, I thought I'd ask Dr. Binhammer if there's any questions from the audience, or Chai, if you have any comments, or Paul, if you have any comments.
No, it's great, Jay, and just have no questions at the present time.
All right, very good. Okay, so the next topic that I'm really passionate about is microsurgery. And just interestingly for me, where I trained, there wasn't really much microsurgery going on. But then I went to the University of Washington. I worked with Doug Hannell as my mentor there, and I just became fascinated with it. And so the kind of the beginning questions is, how did you develop an interest in microsurgery? I know you talked about, going to Kleinert and things like that, but you could have gone through plastics and maybe not have focused on microsurgery. So what were your early, exposure to it? What drew you to it?
Well, I like to fix things. I used to work on cars a lot. I used to be able to fix anything. I mean, when I was in college and medical school, my roommates would say, hey, can you fix the sink? Can you do this? Can you do that? I've always fixed things. And in San Antonio and general surgery, there was zero microsurgery. I had no idea about that. I remember when I left, one of the orthopedic surgeons said, oh yeah, you're going to go up there to Duke. You're going to be doing all these replant takebacks every night, which wasn't quite the case. But I wanted to be a vascular surgeon actually when I started general surgery.
Okay.
So I realized all they did was chop a lot of legs off after I got there, and I didn't like that very much. But, I got to Duke and they did a lot of, I wanted to do reconstructive surgery. I wanted to fix things. I wasn't that interested, never was very interested in cosmetic surgery. I mean, it's fine for plastic surgeons that want to do that. I just didn't want to deal with it. But I'll tell you a funny Doug Hannell story, because he was a super fellow when I went to Louisville. And when I was first there, Doug would hammer me saying, why did you do general surgery? It's a dead specialty. What a waste of time. Why did you do that? And I'm like, well, Doug, that's just what I did. I don't know, So one Friday night, they're in the OR, I'm on call, and a guy came in shot through the brachial artery. His hand was viable, but he had no pulses. I got an arteriogram. So I went up and showed him to Doug, and he said, well, let's, do it first thing in the morning. And I think I'd been there a day or two. When I was in Louisville, I'd take extra call, whatever. And it was a Saturday morning. I was fairly new. I hadn't got to do very much. We had conference, and I knew Doug was going to do it. There were going to be 30 fellows in the room. And so I'm in the scrub room, putting my clothes on. I'm going to go home. I'm not on call. And Hannell comes in and says, what are you doing? You're not going to scrub for this case? And I said, Doug, I don't know how to do very much, but I can fix a brachial artery. Okay. And I said, I don't know anything about hand surgery, but I said, I'm not going to sit in the third row and watch somebody else do this. And Doug said to me, well, will you assist me? I've never done one before. So it was awesome. So I helped Doug vein graft this brachial artery, and that kind of cemented our friendship after that. So, but I like to fix things. And it was amazing to me that you could take these wounds and yet you could borrow tissue. I give a lecture to the medical students and actually the undergrads as well. And I have a picture of an anatomic drawing of the hand all taken apart. And I go, if I didn't fix this, I'd probably fix this. And I have a picture of a Ferrari engine taken all apart. So I think the hand for me and microsurgery was probably the most complicated thing you could do, almost, I thought, in surgery. So I couldn't figure the brain out. I'd have been a terrible brain surgeon. So I had to do something that was more mechanical.
Sure. How do you counsel young surgeons who are considering that as a career, specifically microsurgery? And what I think about is, some people that you meet, that you're, trainees that you're working with, you may think that they're capable for it, but maybe they don't have an aptitude toward it. Or some have an aptitude and want to do it, but they're not technically skilled to do it. How do you address that? How do you approach that when you're working with trainees that, are kind of looking towards microsurgery?
Well, in my years of experience, there have been very few people that couldn't do it technically. I mean, some of the best technical microsurgeons you ever see are the people that work in the labs, like Frank, who was in Bob Ackland's lab, or a woman named Sue Mackay, who was in the lab in Australia. They could sew a 0.5 millimeter vein in a rat with 100% patency every time. And I've seen very few people. I had one fellow who was a wonderful surgeon, could have taken care of my kids anytime, but he had visual problems and he just couldn't do it. And I had another couple, but not very many. I think women are particularly good at microsurgery in general, not to be sexist or make any generalizations, but they just pick it up well. And I think they've got to understand that it's demanding work. It's psychologically demanding. Losing a flap still rips my heart out. Yeah. I don't know exactly, but I've done somewhere between 2,000 and 3,000 free flaps, including fibulas and toes and whatever. And I can't remember most of them, but the ones that I lost, I could almost list them for you. Yeah. And the most of them ripped my heart out a little bit. So you've got to be able to handle that. You've got to have the personality for that. And I don't know why I do, but I seem to be able to. And I don't take it lightly. I think sometimes the fellows think because I'm not there screaming that it doesn't upset me. It terribly upsets me when we have a flap go off. But nonetheless, I counsel them that it's difficult work. It requires work at night sometimes, but it's tremendously rewarding. You know, I have people that I've done reconstructions on 20 years ago that I still hear from once in a while. I have a young woman that when she was 13, I think I was telling you, had shin splints and necrosed both her anterior compartments. She was a stud little soccer player. And I did bilateral innervated gracilis on her the same day. And 2 years later in high school, she ran cross country. And now she lives in Denver. And she just recently emailed me to give me an update. And she's doing fine. And so it's probably one of the most rewarding things you can do. But it's not the most remunerative things you can do. You know, when I was in San Antonio, my partners that did shoulder scopes, and it was fine, I don't do them, would do 4 or 5 shoulder scopes, and I'd do 1 free flap, and they'd go home and sleep, and I'd be worried about it all night and make about 1/4 or 1/5 of what they made. So you've just got to be aware of that. But I've never been in it for the money, and you know, I've been adequately compensated my entire career, and so you know. I just think I have the best job in the whole world. I fix stuff and I'm pretty good at it. So I think the enthusiasm helps as well. So.
Yeah. It's interesting because I think there is an aptitude that some have, maybe not the technical skill, but the mental aptitude to go through that process of trying to do it because it's so difficult. But there is a lot of reward that's not monetary. You know, like my flap patients are people that you have to establish a lot of trust with them before you do those reconstructive surgeries. But then you also have these great relationships with them that you don't have with other patients. Like some of my just routine hand surgery patients, they're great people, but I don't have the same relationship as I do with people I've done reconstructive microsurgery for.
Yeah, well, I'll have to say some of the people that I've lost flaps on have become pretty good friends of mine because I spend so much time talking to them. I had a 16-year-old girl who came to me years ago with a thing on her thumb that the dermatologist had been scraping off for years, and she had no thumb pad on her right hand. And it was some benign, you know, dermatology thing. I don't even remember. And so I said, shoot, we'll take this off and do a toe pulp transfer. It'll be perfect. So I took it off, did a toe pulp transfer. The path came back as epithelioid sarcoma. 16 years old. I hadn't done nearly enough resection. So I had to go amputate the toe transfer. Actually, I did a wraparound. So I took most of her toe and her thumb. And I was distraught. I was completely distraught. I thought I've killed this young woman, you know, et cetera, et cetera, et cetera. Well, about 6 years ago, I was in San Antonio and this lady came and saw me. She was like 36 and she had carpal tunnel. And I'm looking at her hand and talking to her. And she said, "You don't remember me, do you?" And I said, "No, I'm sorry." She held up her other hand and she had no thumb. And her name was Sarah. And I went, "Oh my God, Sarah." I said, "Oh God, I'm so sorry." And she said, "Dr. Pederson, I'm alive. I've got 2 kids. I've got a great husband. I'm a nurse. So thank you so much." So despite the fact losing that flap, you know, the patients, as you said, are great.
No. How did you approach developing a practice in microsurgery for those who are kind of early in their career? I know for myself, my first position in academia, I was the first person to do microsurgery in my department. So it was a huge uphill battle to even developed microsurgery there in that hospital, in that service. What were your early experiences?
Well, I mean, you go somewhere where they've never had it. I went back to on the faculty in San Antonio, and Jim Heckman was the chairman. And I'd done a lot of flaps at Duke with the orthopedic surgeons. And I went to Jim Heckman and I said, "Hey, Dr. Heckman, I'm Chris Pederson." He said, "Yeah, I remember who you are." I said, "Well, I do microsurgery and I work with the orthopedics. That's what I do. I do coverage." And he goes, "We haven't needed that for 20 years. I have no idea why we would need it now. I mean, their treatment for an open tibia fracture was hyperbaric, drill holes in it, and maybe it'll granulate. But I went to the other orthopods and said, hey, if you need any help with a tough case, just let me know. You don't want to go in and say, I'm the world expert, I can do everything. That's always a mistake."
Yeah.
I did head and neck reconstruction. I went to the oral surgeons. I went to the ENT people. They all went, no, we do our own flaps. We can handle this. But I said, well, if you get a really tough case, just call me. Just call me. Well, 10 days later, I got called in San Antonio from Fred Corley, who was the hand surgeon at the time. And that was my first free flap. And I think I did 50 the first year I was there. So I did about one a week. And then I went into practice. Well, nobody was doing free flaps in private practice in San Antonio. So I went to the head and neck surgeon. He goes, well, we do pack flaps. We do our own flaps. I went and talked to a bunch of the orthopods and they went, no, we don't need that. We can handle it. And I said, well, if you get a really tough case, call me. So the oncology guy and I'd done a ton of oncology reconstruction. One day I had this allograft and a humerus that was infected after radiation. And he called me and said, I don't know if this is the right case, but I got to do something. So I went and did a free fibula on this patient, healed up. And I remember he called me at about 7 or 8 weeks and said, this is healing like it's alive. And I'm like, well, yeah, it is alive. And then the head and neck guy called me several months later with some awful infected mandible sticking out of the jaw saying, a pec flap, I did a pec flap, it failed. Well, I ended up doing 600 or 700 head and neck free flaps with that head and neck surgeon before I left San Antonio. And he's one of my dear friends now. And the orthopedic oncologist was at the university. He called me for every case to reconstruct nearly everything. So I think you need to be humble and say, if you need to get a bad case, call me. I had a fellow who went somewhere and went and joined a 40-person orthopedic group. And he goes, there's no flaps here. And I said, give me 40 orthopedic surgeons and I'll find some flaps to do, So, but it just depends on your attitude. That's what I wanted to do. And I don't think you go to people and say, well, I'm the best microsurgeon in the whole world. You just say, well, I can do these cases. I'll be happy to help you if you get something tough. And certainly that's how I did it. And it worked pretty well.
I've had a similar experience where I always try to be a good player in the sandbox, so to speak. Like I've only been at 2 different academic institutions, but in both places, I just try to, wherever I can fit in and help people, that's where I started. But anytime someone would call, I'd help them. It didn't matter. Like one of the things, if you tell people you do microsurgery, if they call you and you don't have a plan for how you're going to do it, when you're going to do it, how you're going to take care of it, so you kind of got to be ready. But I would say that I agree that if you're available to help people, your practice will build. And even I had the same experience with the oncologist. They had always used the plastic surgery service, but because I was more available and I would always help, then within the first year, I was doing all the free flaps for our oncology service for orthopedics.
Well, I would add, you have to be available.
Yeah.
And I have always bit my schedule to fit theirs, always.
Yes.
Even if I had to cancel clinic or change something. There was a young plastic surgeon, fairly young, who came and lectured us at Baylor a couple of years ago. And this person said, that availability, affability stuff, nah, don't worry about that. I tell them when I want to do the case. I can't imagine a worse attitude.
Yeah.
I don't see how this person ever got a practice going because I literally, even 10, 15 years after I'd been there, the head and neck guy would call me Monday afternoon and say, we got to do this case tomorrow afternoon, Pederson. Well, I'd have to cancel my clinic. I think the ladies in my office hated me. I do the same thing now at Texas Children's. The surgical oncologist called me last week and they've got a kid with a forearm sarcoma. I don't even know what I'm going to need to do. I've never seen the patient, but I canceled my clinic tomorrow. So that I could help them when it was convenient for them. And so I think you need to be willing And as you said, if the orthopedic surgeons called me in the middle of the night and said, "Oh my God, I can't get this knee closed. You know, what am I going to do? Or this hip?" You go in and help them. And eventually they go, "Man, you know, it doesn't mean it gets better. It doesn't mean they quit calling you in the middle of the night, but they do occasionally send you a few things that aren't in the middle of the night." So
yeah, that's for sure. All right. So what areas in microsurgery, as you've seen the development of microsurgery, especially here in the West, like US and Canada, what areas do you think that we're leading in? What areas do you think we are not leading in compared to, I think of like Europe, Asia, China, Japan. What are the areas you think that we're doing well in, but what are the areas you think we're lagging in regards to microsurgery as a field?
well, I think we're doing well in general. I think probably this is AO, but probably we lead the world in microsurgical breast reconstruction without a question. And again, that's microsurgery. It's not orthopedics, but we certainly lead the world in that. We lead, whereas we're up with anybody on soft tissue coverage, use of new flaps. I think our replantations are declining. I think it's probably due to reimbursement. And I think, you know, in Japan, they're doing this ultra microsurgery. I mean, some of it, I have tremendous respect for Isao Koshima, and I know many of the Japanese surgeons who are technically superb. They have great judgment, but I'm not sure that we need to replant the pulp of a finger, for instance, and do a 1/4 of a millimeter vessel. I don't think our system could afford it. I don't think, but you know, in Japan, the patients are covered. They can be in the hospital 3 or 4 days. And it certainly requires a lot of technical expertise. You know, they're doing a lot of lymphatic surgery, but we do a lot of that here. You know, I did a lot of research into that when I was in Australia 30 something years ago. And it doesn't work that great, but people are reinventing the wheel these days, I think, with the lymphatic surgery. But I think we're doing fine in most respects. I think, again, replantation, our numbers are down. And again, I think it's because reimbursement has gone down. And I think that's one of the issues for young microsurgeons these days. You know, the curve for reimbursement is not linear. You know, you're supposed to get paid X number of RVUs for, you know, X number of dollars per RVU, but the dollars go down with the more RVUs because I've seen the curves for insurance companies. So, you know, I think that's unfortunate. There are a lot of people, Scott Levin among them, my dear friend, are trying to get reimbursement better, but I don't see that that's going to happen. So, but I think in general, we're doing pretty well, Jay, in microsurgery. You know, a few things maybe not, but again, the indications of ultra microsurgery, I think, are really few, frankly. I applaud those that do it and get good results, but, you know, I'm not sure that that's necessarily applicable to every society.
Okay, very good. Before we go on to our last topic this evening, Dr. Benhammer, you guys have a question?
Yeah, thanks, Jay. So from Rodrigo Bolanos, what was your set of mind and how did you feel being one of the authors of one of the best, or should I say the best, hand surgery book in the world? Green's positive and negative things it brought to your life.
Well, I have to thank Dr. Green for getting me involved with that. Before I got involved, there were no plastic surgeons as editors and no real microsurgeons. It's a tremendous amount of work. It's unbelievable. It's gotten easier with everything online, but we had when I was in North Carolina, I had a patient, there was a lot of furniture out there that sold me, I saved her hand, and she sold me this 12-foot banquet table out of walnut. Well, it was covered with chapters for like 6 months. My poor wife would say, "When are you going to move these?" I go, "Nope, this is my table for 6 months." I would say it's mostly positive. It's been a great experience getting to work with the other editors, getting to know the author, chapter authors. And frankly, you learn a lot. You know, a lot of people say that writing a chapter is a waste of time, academically at least. Well, you know, I don't think so. I think if you have to write a chapter about something, it makes you order your thinking about that subject. You have to explain it to someone else. And if you can't explain it to someone else, then you don't understand it very well. I always tell my residents and fellows, if you can't assist me in an operation, I know you don't know how to do that operation very well. And so I really try to impress that. And it's the same thing writing a chapter. If you write a chapter, you have to be able to organize your thoughts and make it understandable for someone else. So I think working on the book for me has been wonderful. This may be my last edition. We're working on the 8th edition right now because it's just so much work. But the rewards, we get paid a little bit, but not much. But you know, there are only 3 publishing companies now, and they're all in the Netherlands, and they're all penny pushers. And we're now content providers. I would have to say David Green had a wonderful relationship with the chair of Churchill Livingstone. And he knew him personally for years when the early book came out. Well, I mean, we seem to have 3 different developmental editors every time we do the book. And they change in 3 months, we'll have another one. So despite the fact that it is apparently one of Elsevier's best-selling books, you know, we're content providers and it's just another book to them. So that to me is a bit of a disappointment. But overall, the book has been really wonderful for me.
All right. To kind of our final topic tonight is just really similar questions, but in just relation to hand surgery itself. A question that I'm curious about is, this could be hand or microsurgery, but think back some of your early cases in your career, or even in the last, half of your career or the middle, kind of some cases that were so difficult that stand out to you as milestones in your career. Can you give us a kind of a flavor of, seems like that this difficult case that I accomplished led to these other developments for me in my career?
Well, I think doing the surgery is complicated, but figuring out how to do it and what to do when. And I think the most important thing for young surgeons is often in a complex reconstruction, you have to set it up for the next operation. You can't just blindly. I mean, when I was a resident, we put the whole latissimus on the end of a foot like a softball. It was ridiculous. But I had a gentleman a number of years ago in his 30s who amputated his arm through the mid-forearm in a auger. And one of my partners put it back on, spent all day Sunday. Monday night, it had gone off. She had taken him back several times. I went in and looked at this, and his arm was connected by the bones and by some vein grafts, and that was it. The tendons were not connected. The nerves were not connected. And I went up to his wife, and I said, this is ridiculous. We need to take his arm off, get him a prosthesis. And she said, no way. Well, I proceeded to do maybe 20 operations on that gentleman. And he has minimal function, but he has sensation. I ended up doing a latissimus to cover it that night. I took all of his vein grafts out. I took most of the skin off his legs. He got a non-union. I had to do a double barrel free fibula, and I had to hook all of this into vein grafts. Then I went and did an innervated gracilis, and I grafted his median nerve with all of his sural nerve. He actually has some grip function, and he has protective sensation, and he tells me he would do it all over again. And that case really taught me how to stage things. And again, I think it's the hardest thing for young surgeons. Don't just cover it. What do you got to do next? Yeah. And then I had a couple of patients actually that I moved parts of hand from one side to the other. I had a young woman who got both her hands mangled, and she didn't have a good hand on either side, but one side she had no wrist and no thumb. The other side she had the thumb and no fingers and a wrist. So I took her 3 fingers and moved them to the other side. Of course, it went off that night. This was a very attractive 30-year-old lady whose husband was in the Air Force in San Antonio. And I had to take her back, and I was sweating bullets, but I saved it. And eventually she had very good hand function, had a couple of kids. She came to me 5 or 6 years ago wondering about a hand transplant for the other side. But I think those cases, I had a gentleman who had a paralyzed arm on one side and chopped off his fingers on the other hand. And I moved 2 fingers from the paralyzed side to the good side. And that was it had a great result. It was a wonderful result. When I was in Australia, Wayne Morrison would sometimes take a ring finger from a normal hand and move it over to a metacarpal hand. And he was roundly criticized by people, but actually it gave a very good finger. It was much better than a toe. But I think the difficult reconstructive cases where you have to do multiple things and you have to stage them, I asked me about specific cases. Another one is a 3-year-old I was called in to see. His parents were both physicians. He had meningococcemia. Both his legs were dead. His right arm was nearly dead. I had to amputate both his legs below the knees, and I was going to amputate his right arm. And we're in the pre-op holding, and his parents are crying. I'm about crying. And I said, all right, as a surgeon, we should probably take his arm off. But as a dad, let me see what I can do. Well, I ended up saving that kid's arm. I used his peroneal nerve to graft his median nerve, and he actually has good sensation now. I did 2 innervated gracilis, one for finger flexion, one for wrist extension. And he's going to University of North Carolina now. And actually, he's going to be in a documentary that's coming out in August called Boys State, which we have. I think they have it in every state, but in Texas, high school kids go and form a government and learn about government. And he's one of the stars of that show on 2 prostheses. So I think the main thing I learned is the resiliency of the human spirit despite these awful injuries.
Yeah, that's amazing. Thank you so much. It's each one of those, a vignette is so incredible. Thank you. Where do you think in the field of hand surgery itself, what do you think we've lagged, or that's something we haven't achieved yet that you thought we should have achieved by now, having been in hand surgery for so long?
Well, I wish we could do a better job with nerves, brachial plexus and proximal nerve injuries. I thought we would figure out a way to speed up regeneration. We haven't really done it. I mean, there's some great pioneers like Susan McKinnon, et cetera, and the nerve transfers have been a big boost, but I really thought we would figure out a way to make nerves regenerate quicker, and we haven't done that yet. I did a little research project when I was very young on using polyethylene glycol to break down early nerve injuries and reunite the nerves. And actually, there's a company working on that now. And I could never do it, but that may be something that where they're getting 10 or 15% immediate reconnection of the nerves and function. Mm-hmm. And think about that, if we could do that with a median nerve injury or brachial plexus. But again, to date, that's been disappointed. And I'm frankly disappointed that the hand transplants haven't done better. I know there are people still doing them. Scott Levin, again, one of my former residents, a dear friend of mine, and those are the guys that'll probably push it till we figure it out. But we did one in San Antonio. It unfortunately, it turned out okay, but I didn't get to see the patient very much. He was in the military, and the military kind of claimed that, which is fine. But, I have examined a number of the patients. Some of the distal ones have done quite well, but the proximal ones don't do well, which is not a surprise. Mm-hmm. And I think it also, that comes down to we need to figure out how to get our nerves to regenerate quicker.
Sure. As an educator, what's your opinion about the surgery, the training involved to become a hand surgeon? Are you pleased with the current system? Some people talk about doing shorter residency and then more fellowship. What's your thoughts about that?
Well, I did 5 years of general surgery, a couple years of plastics, a year of hand, a year of micro. I think it probably would be better to shorten the initial period and just spend more time in hand surgery. Interestingly, I just came off the board of plastic surgery, but I was convinced that you should do general surgery and then plastic surgery. I mean, I learned how to be a surgeon as a general surgeon and how to take care of patients properly. But our integrated program people, the results on the written exam went up dramatically when those people finished. So they had spent 5 or 6 years doing a lot of plastic surgery. Yeah. So I think our product would be better, Jay, if we could have a 3-2 or 3-3, perhaps, pathway, if you want to be a hand surgeon. I mean, hand surgeons do not need to know how to do liposuction. They do not need to know how to do total hips. And so I think that training is valid in terms of being a surgeon, but I'm convinced now that you can learn that doing your specialty.
Okay. We've got some time left. I think we're going to finish with some questions from the audience. So Paul, you have another question?
Thanks, Jay. So Lander Cabrera Marti asks, how do you think microsurgeons differ between plastic surgery and orthopedic background? What could the orthopedic microsurgeons learn from the plastic microsurgeons? And I might add vice versa.
Well, I think they can both be equally good. I have 3 or 4 orthopedic surgeons who were my handfellows in San Antonio who went out to various places and were doing head and neck microsurgery, all kinds of microsurgery because the plastic surgeons didn't want to do it. I would say in general, and this is a generalization that doesn't apply to everyone, but soft tissue handling is sometimes an issue with orthopedic trained fellows. And I think they could learn a little better soft tissue handling sometimes. But as I said, the people that I mentioned that I didn't think should do microsurgery were both plastic surgeons, not orthopedic surgeons. I mean, I had a fellow who was an offensive lineman in high school, a big old giant dude. And he had good hands. He was quite skilled at microsurgery. So, you know, I think the plastic surgeons probably, my residents are so afraid of K-wires and stuff. It's just ridiculous. And that's not microsurgery, but in terms of doing replants and stuff, you know, I tell them, hey, you know, it's a big puzzle. The orthopods just try to make us think it's complicated, but it's just a big puzzle. Put it together. But I think, I don't think that orthopedic microsurgeons are necessarily a step below plastic surgeons. I think it's just the background training, which they can catch up on. And, you know, but I think the only issue might be soft tissue handling when they start out as microsurgeons. That's all.
Very good. Well, I think that we'll go ahead and close for this evening. Is there anything else, Chai, that you would like to add?
No, you know, I love the candid nature of Dr. Pederson's remarks. And so I'm going to be a little inflammatory and ask you, what are your views on nerve allografts?
Well, I think they haven't been worked out enough. I don't want to be inflammatory. I think for non-critical nerves, they're fine. But we all know that allograft causes Schwann cell senescence. I think that's probably the issue. But it's my opinion, and I have many good friends who are involved with this, that it's been way oversold. One of the reps told one of my fellows several years ago that there was no indication for a sural nerve graft. And I mean, that individual has no business. This is a rep telling my fellow about the indications of a sural nerve graft. And I know all the people involved. And they've been after me, not bad, in a bad way, but, you know, I think it's been oversold. I have seen patients that had allografts that failed in my practice that I can't find this was reported anywhere, lost to follow-up, et cetera. So I think it has its place, but I think it's probably overused a bit. I have to close with saying that I ran a panel on Saturday afternoon at the Hand Society several years ago on nerve surgery. And at the end, it was allografts and nerve grafts, and there were good papers. And I finally said, okay, there were maybe 80 people in the room. And I said, how many people here, if they had to have their own nerve fixed, would they want an allograft? And one person raised their hand. So, you know.
It's an interesting idea because for the younger surgeons, they may not have even seen a sural harvest. And so it's an easier choice for them to just use something that's off the shelf. But it's a great technique that you should know as a reconstructive surgeon. There's just going to be some things that you can only fix with a sural autograft. And some of my younger partners that I've had, when I take a sural graft, they think that I'm causing morbidity. And I've had very few patients who complained about the harvest from a sural graft, a long term, like at 6 months or a year.
Well, no, I looked up 250 patients I had done it on. We never published it because it was a research study and the company wouldn't allow it. But we had one person that had a neuroma. On average, the area of numbness went down 40%. And in younger people, it went away completely in 2 years. But the interesting thing is I ran a panel at the Hand Association a couple of years ago on allografts, and I looked up every paper I could find on primary digital nerve repair, primary repair. And then I looked up the results of allografts. The reported results of an allograft is better than the reported results of a primary digital nerve repair. So you can make of that whatever you want, but.
Yeah.
So let me push the envelope a little bit further here then. As educators, mentors, teachers, and perhaps thought leaders, do you think it's incumbent upon us to make sure that our trainees learn basics of nerve grafting with autografts a little better than they're doing?
Absolutely. No, absolutely. And I mean, there's not, they're not long allografts anyway. So, I mean, I'm doing a tumor case tomorrow where they're going to probably take out the median nerve 7 or 8 centimeters. Well, I mean, it's a 8-year-old and I would use autograft no matter what, but there are limits to the, I don't even know what the length of those things is, but I also saw a patient a couple of weeks ago, a teenage kid, that it's the, radial side of the thumb. And I suggested an allograft for that patient. I think for a non-critical nerve, it's fine. But I think absolutely, we must teach our trainees how to do a sural nerve autograft. Absolutely.
And then as a segue from there, what are your thoughts about, I mean, you mentioned alignment as being one of your trainees. So let me take that football a little further. And how do you deal with posterolateral corner injuries of the knee, where they have the lateral popliteal nerve out? What is your thinking? How do you deal with that as a microsurgeon?
The lateral popliteal nerve out?
The posterolateral corner of the knee with the common peroneal nerve.
Oh, common peroneal?
Yeah.
Yeah.
Oh, I've fixed many of them. I mean, I've seen them with sutures through them. I've seen them scopes go through them. I've seen them avulsed. If they're avulsed out of the sciatic, it's a difficult problem to fix. Mm-hmm. But no, the peroneal nerve is very fixable. The orthopedic surgeons say it doesn't come back, but it's eminently fixable if you can get a proximal end. With knee dislocations, what you're mm-hmm. talking about, it can be difficult because you may not have a proximal nerve to start with. But I've had a few that I've put 15 centimeter grafts in, and they mm-hmm. got some foot dorsiflexion back with autografts. So it will, I'm talking younger, 18, 20-year-old athletes. Right. So it can work.
That's good to hear, because the data is very split on this arbitrary 6 to 7 centimeter gap or defect or injury, which causes a outcome to be either good or not so good.
Well, I once heard Hanno Malaysi years ago say that it wasn't the length of the graft that was the issue. It was the length of the gap. Well, at the time, I thought, well, it's the same thing. That's goofy. His point is that a nerve will grow down a long graft. But if you've got a large gap, the issue is motor and sensory realignment. Now, the good thing about the peroneal nerve is you can throw away the sensory part distally. I've fixed a lot of them. We know where that is. And you can target motor only. Now, proximally, it's difficult to tell. But you can take that whole thing and target the motor part of the peroneal nerve and usually get somewhat of a result. Because, and if it's in a terrible bed, no, not necessarily. If it's horribly scarred, if it's an open injury, maybe not. But I think with a decent nerve bed where there can be some revascularization, I'm disappointed if my nerve grafts don't work, frankly. So, and that sounds arrogant, and I'll be in trouble. And the one I do tomorrow won't work. Never get arrogant, but nonetheless, I think nerve grafts should work if they're done properly.
Great, thank you, Jay. All yours.
Well, we just want to end by saying it's been a real pleasure to have you with us tonight, Dr. Pederson. Thank you so much for your career, your passion, your leadership in our field. You're an inspiration to all of us, and we just want to say thank you.
Well, thank you so much, Jay, and the AO Foundation and everybody. And for all the young surgeons that are still out there, stay excited. And microsurgery to me is still magic a little bit. When you let the tourniquet down, or when you let the clamps off and the finger turns pink or the toe transfer turns pink, it's still a little bit magic. So try to keep some of that magic going, and you'll keep your enthusiasm, I think.
Very good.
Thank you, Dr. Pederson.
Right.
Thank you. Thanks, everyone.
Thank you.
Good night.
Good night.
Good night.